Okay, so this presentation is on the basics of implementing evidence-based practice. So we've already seen the complexity of how theory and our beliefs change over time, and in particular to low back pain, they involved a lot of different kinds of studies and a lot of different kinds of clinical experience that combine to reinforce or challenge our beliefs. And so we understand that the process is super complex, requires lots of information, and so the big question for you is, if you're treating in the clinic, how do you know what to pay attention to allow that to influence your beliefs? And so that's the heart of this class, is like what to pay attention to. In particular, this concrete example should have resonated with you, where we see that what we believe about the herniated disc really causes these different actions, and it's really the beliefs that matter. And so the whole focus of the course is like, how do you use evidence to influence your beliefs, and how do you balance that with clinical experience? So one way to kind of start to approach this is to ask the questions, what do patients really expect of a physical therapist? And so there's a qualitative study that was done in Sweden that asked patients about their expectations from physical therapy. And honestly, they were expecting to get some, idea of specific exercises and concrete things that patients wanted of them. And what they got was something slightly different. The overreaching theme that emerged from the interviews was not what we had anticipated. We set out to explore which physiotherapy interventions were preferred, but ended up with other key findings because of the participants in the study did not express strong preferences for particular methods. Instead, they expressed great trust and confidence in the physiotherapist's skill and competence, and therefore preferred to either collaboratively decide on treatment options or leave the decision to the physiotherapist, meaning that you really, in the end, are going to be able to influence your patients, and that's really why they're coming, not because of some preconceived idea about treatment. And so this is a graph from that same study, and this is the citation itself, where you can look at, they kind of bend these different areas, but what's pertinent to our class is this idea of the expectation of professional management. And if you read here, patients' expectations were an explanation of problems and how to solve them. Again, this will stem from your beliefs. Treatment methods should be based on evidence, so they expect you to be accountable, having no treatment preferences, meaning they're open to your influence, and confidence in your professional judgment. And so all of this stems from knowing things that are very concrete, that come from data about their particular problems. So the challenge is for you to measure up is, how do you balance clinical experience and unproven evidence with evidence-based care? That should be a frequent question. How do you kind of include some alternative medicine or not? And does it really matter if no one's actually holding you accountable? These are all the questions that you'll face off in the clinic, and hopefully will come up in class. So in essence, to fully embody this model, because it takes a lot of work to do the biopsychosocial model, to really embed that with biomedical, you have to really believe that the benefits are there for the patients. And a good example is all of this new kind of theory about beliefs and fear and self-efficacy has really captured our imagination, but that would only occur because of evidence. So the challenges to EBP essentially are time, the complexity of the articles themselves, the massive amounts of information that's coming in that's difficult for you to sift through. And so the essence of EBP was to say to clinicians is, yes, these are all significant problems, so we need a method for you to filter out information that's not likely to change your beliefs, and information that's not likely to improve your clinical practice, and help you focus on just those studies that have the potential to really be included on that timeline. In other words, studies that are going to change the way you think and change the way you practice. And in essence, what I'd love for you to come out of the class with is, at the end of the day, is when you look at research studies, you don't think of them in terms of hey, this is a technical piece of information that I'm unlikely to use clinically, but rather the ones that you choose are ways of looking at how practice is effective or not effective, and what's some potential new ideas that you might be able to innovate with or create a new service, and that might lead to innovate, something really different for your patients. And so that's really the goal. And so I really love this picture of Michael Jackson, because essentially, to me, looking at studies is looking at how our treatments really work in an unbiased way. So you start by looking at the man in the mirror. So the steps for EBP are pretty straightforward, and we're going to explore these throughout the semester. So the first step is you have to have a question or something you're curious about. So, for example, in the low back pain guideline, there were many different points of change, right? And those points are because someone asked a question. So, for example, somebody asked, hey, does disc herniation predict outcome? And the answer was no. And so then, even though it was no, they said, well, hey, I wonder if psychosocial factors with disc herniation predict outcome. And then the question that was answered was, hey, psychosocial factors predict better. So that's a good example of where there's something controversial that you're seeing in the experience of your patients, and so then you have a question about it, and then research can answer that question. So that's the first step, is you have to kind of enter the literature with a question. And so there's two types of questions. There's like background questions that essentially ask for kind of general information, like how many people have disc herniations, where do they typically occur at what ages do they occur at. Those kinds of things are kind of background questions. They don't really lend themselves to research. So research is more about foreground questions, right, where there's a controversy about how something should be managed, or whether two things like disc herniations or structural damage in the back and psychosocial factors interact, but something that's controversial or unclear just on the surface. That's a better foreground question. And so you can see here, that you can see patient and no problem, intervention, diagnosis, comparison, or clinical outcomes. This is this Pico format. So most foreground questions you can be formulated into this Pico format. I would suggest you kind of review this as you study the slides. But this kind of foreground question really evolves as you develop skills and practice. And so this is always kind of a challenge for where you're at now clinically, and it was kind of exemplified by when I asked you to discover an innovation for our discussion last week, and you came in and then you found out that the faculty had kind of identified really different types of questions than you were used to. And so essentially the foreground questions come from areas of cognitive dissonance. Like if we take Dr. Cuddiford's question, where he recognized that in his mind, he knows that the tendon can take a lot of load, because he's worked with runners and high-level athletes, so he knows the tendon can be loaded a lot, and yet the current protocols for rehab, we're calling for really low load exercises. And so there's cognitive dissonance there, meaning that he knows one thing, and then the recommended treatment doesn't really match the body's capabilities, right? And so that's a great foreground question that you're always wondering, geez, if I work them harder, would that be even better for them? Or am I just making the tendinopathy worse, right? So that's a good example of cognitive dissonance. So the best types of research foreground questions come from where there's conflict, and so between what we actually do and what we know. And so what we can do is, as a new person to this, though it's not always easy to come up with those foreground questions, so we're gonna help get you started by looking at what types of questions are typical in terms of practice. And so the first one, and I'm put these in the perspective of your patients, because I thought that might be relevant to you, is their first is if you're making a diagnosis about, say, a disc herniation or a muscle rupture or ligament rupture, the first is, are you sure that the test works? So are they actually correct, and do they give you an accurate diagnosis? Completely fair question. You want to know the answer. Your patient wants to know the answer. In terms of prognosis, this is more interesting because it's like, can you really predict the future? And so your patients might say, what factors are going to be important to my outcome? And this is all about beliefs. If patients believe that their back is broken because they have a disc herniation, well, that person it may be very difficult for them to recover. And that's how come the psychosocial factors turned out to be more powerful than the structural factors, because it's about the patient's beliefs, right? And so measuring beliefs at baseline then may be a valid assessment, because you know that you're going to have to challenge them in order to kind of prevent that bad outcome. Okay, and if you can't change it, their prognosis may be set. Okay, and so this is the relative importance of factors versus just generally how long my recovery will take or what kind of limitations might I end up with. And I want you to really let this sink in, that actually for prognosis, what you're looking for is factors that make the outcome different. And so the other piece is not just factors, about like beliefs, but they could also be factors about the physical, impact of the disease. So strokes that have higher severity have less functional recovery long term, that kind of thing as well. So severity is kind of a classic prognostic factor. Now, therapy asks a little bit different question, which is, hey, if I invest in this treatment, it could be a drug, it could be physical therapy. If I invest, is there a benefit to me that's worth the cost? So in other words, I have this prognosis, but can I actually change that outcome? So for example, we know that beliefs matter for prognosis, but if I tried to do a cognitive behavioral treatment with that person, could I change, if I change their beliefs, i.e. I do a treatment with them, will that actually alter the outcome? And what's the cost of that? Do I have to come 10 times to treatment to get the benefit, or do I just have to come once and I experience the benefit? So with therapy, there's always a cost benefit. Like what's the outcome? How much can I change my overall outlook? And then what's the cost of achieving that? And the cost can be time, or it can be actual money. And the last kind of study that's important for us as PTs is what kinds of outcomes should we measure and use in our clinic? If we're trying to assess our patients, we want to know what their values are and what the validity of those tests are. And so the outcomes, it directly impacts how we develop theory and think about patient care. So those are our 4 buckets, and those are the 4 places where most of your questions are going to come from for this class, and also form the essentials of clinical care. So what we want to do is start with asking a clinical question. And so the Pico format is where you kind of include each element. So the P stands for patient or problem. The I is an intervention, which would be a therapy question. The type of diagnostic test, which would be a diagnostic test question. And then what prognostic factors you're looking for. Severity, patient beliefs, age, obesity, things like that. Those might be prognostic factors that are important to know for a clinical outcome. So the I would get some type of any one of these that you're kind of interested in, and then what you want to compare it to would be the C. So if we had an intervention or therapy that was interesting to us, like exercise, and say the comparison was surgery, so then we would want to compare those two, so that would be the C. In terms of a diagnostic test, you'd have the test here, and then the gold standard would be the C. And then for the prognostic factors, it would be a yes on the prognostic factor or no on the prognostic factor. And so those are that's kind of how the Pico question would work, and then the O is the outcome. And so the reason we start with the Pico format is it gives you a way of structurally knowing what to put in your question as a new person, and it also gives you a way of searching the literature for people who might have done research on a similar question. So those are the two reasons. One is for you to kind of structurally know how to frame a question that's answerable, and second is maybe to look for or identify research or studies that have already been done. So let's talk about the O for a minute, because the O kind of helps you categorize a study in terms of whether it's purely theoretical or where it actually is client-centered or has clinical relevance. And so if we look at the ICF model, we noted that really theory-based questions and theory-based studies are going to address the body function and structure level questions. So we know if the outcome of a study is an MRI, for example, or involves kind of strength and range of motion, those are impairment-based things or structural things. So the MRI is structural, range of motion and strength are impairments. So they're really not addressing the patient level problems, which is activities limitations or participations in their life things. So the social roles, work, and play, right? And so essentially, if the outcome of the study or the focus of the study is body functions and structure, well, then it's a theory-based study, and you might not want to read it, okay, unless you know that the impact of those therapies is beneficial to the patient in terms of activities or participation level. Because this is really theory-based information, where this information that's evaluating the effects of the treatment at the activities or participation levels about the impact of those therapies or diagnostic tests or prognostic factors on something patients find very important to them, which is their functional capacity. So another interesting thing about the diagnostic studies is the outcomes here, and same with prognostic studies, are really the accuracy that's achieved by knowing those diagnostic tests. So basically, if you do a Lachman test or a ligament laxity test at the knee, how much accuracy or information does that give you about whether they actually have that ligament problem or not? So if the test has real poor accuracy, then you might not use it. So the outcome here that decides whether the test is good or not is really the accuracy or the reliability. And the same thing is true of a prognostic study. You're looking for pretty much the same thing. It's like, so you want to, because in a prognostic study, you want to predict the future. So you want to know if the future comes true or not. So in essence here, what you're looking for is, hey, if I know that they have really severe stroke, how accurate does that predict their functional outcome 6 months later? Does that mean they're not likely to be able to return to their multi-level home and that they'd be better off in a single-level home? So in other words, I might have to recommend that if they have stairs and they have an upstairs bedroom after a stroke, they're really not going to be able to manage the stairs well. So at the initial injury point, you can start to help the caregivers know that an adjustment is going to be necessary. And the accuracy of that's relevant because in this particular case, the consequences of committing, you might make people move from a two-story house to a one, or if they don't have very good resources, how are they going to manage getting out of their current, multi-level living situation and get to some other kind of situation. So you can see how just simple things like that could make a big difference in people's lives, and they need accurate predictions. And so that's the value of prognosis, and again, it's about accuracy. So the first step is to ask a clinical question. The second step is to find the best evidence. And this is what the librarian will help you with next, and there's many different strategies, and they can be complex. Most of you are familiar with searching at least somewhat. And so, but the first step is going to be to develop a Pico question based on your interests, and then essentially try to see if you can use the Pico format to develop a search from. So here's a couple that I've developed just based on what my interests and things. And so the first was Achilles tendinopathy. So I would look for a search on Achilles tendinopathy, and I might put and proximal trainings and eccentric training versus eccentric training alone, and then my outcomes I might think about would be pain or improved function. So this is something that you may have thought about or heard about, as whereas like proximal control at the hip may or may not help people with Achilles tendinopathy. So the eccentric training kind of represents the current approach. Pardon me. And so we were wondering if proximal training really augments that current approach. So I wondered if there would be a study about that. And then another one that pertains to therapy would be whether you have high intensity or low intensity. And this is the question that Dr. Cuddiford asked. So a diagnostic question, the Pico takes on a slightly different format. And here I've kind of written it out. So can diagnostic ultrasound accurately diagnose partial Achilles tendon rupture? And so what's the cognitive dissonance related to this? It's sometimes about 20% of people with Achilles tendinopathy don't recover. And one of the predictive factors of that is whether they have a partial tear. So diagnosing a partial tear may be relevant early. I wondered about whether ultrasound accurately picks that up. And so essentially the P is Achilles tendinopathy, and again it's non-insertional. The I here is the diagnostic ultrasound test. The comparison is MRI or surgery, and then the outcome is how accurate that is. And so that might be something I could search on. So what we've done so far is ask a clinical question. We've talked about finding the best evidence, and so we're going to cover that this Friday. Then after that's covered, the rest of the class will be spent on critically appraising the evidence and trying to integrate that evidence with clinical practice. And that's mostly a discussion. And that's how far the class will go. But this is the basic steps, okay? And so by this Friday, you'll have had some practice asking a clinical question or seeing that at least modeled for you. And then the other piece is that you'll have a librarian who will walk through how to find best evidence and give you some examples of the resources that you have available to you. And once you find the article you're interested in, the critical appraisal will involve learning two things: a hierarchy of evidence, and also there will be worksheets that you'll use to kind of help you focus in on certain elements of the studies that you choose to read. And then after you get done with those two things, like you applying the hierarchy and also then using the worksheets, you'll kind of step away and get an assessment of how valid or confident you are in the results of the study. And that would then directly relate back to your beliefs. So you'd be asking the question, is this study strong enough to change my current beliefs? So as a student, plan on being strongly engaged in how the biopsychosocial model and the evidence that we read might influence your beliefs in how you treat patients. That's all for now.